Right, perfect. So, in coming up with the title for this, obviously, Understanding Radiation Fibrosis Syndrome and Hodgkin's Lymphoma Survivors seemed like a good title, but I also kind of liked, I wish I didn't know now what I didn't know then, because I think a lot of us going into it, a common complaint I see is, I didn't know any of this could happen, and that happens across a lot of cancer types. And I don't know it would change the treatment because you needed it to be here. But I think it's certainly a common sentiment. So I really want to give an overview of Hodgkin's, how we treat it, why we treat it, and then map that to some of the issues you're having, and then hopefully leave a lot of time to go over some of the questions. So this is a disease we've known about from the early 1800s. Really clinically with these big pathologic lymph nodes back when we couldn't do anything about it. In the early 1900s is where science is just starting to figure stuff out, were the first reports that you could actually shrink the big lymph nodes associated with this Hodgkin's lymphoma with x-rays. It was Vera Peters, pictured here, who was the first person to publish back in 1950 that limited stage, and I'll show you the staging of Hodgkin's, could be cured in some cases, and like 80% 5-year survival rate with radiation. Now, of course, the radiation back then was very different from what we do now. I don't want to use the term barbaric, but it was cutting edge science then, but really quite crude by the standards we have today. In the 1970s, it became the first advanced malignancy, meaning, more than just one localized lymph node that could be cured with chemotherapy. So that was kind of exciting. And, by the 1990s, we started getting more multimodal, meaning using chemotherapy and radiation. And I'll teach my residents, the reason we have Hodgkin's lymphoma and all the other lymphomas, because if you had to have lymphoma back in the 1960s, 70s, 80s, 90s, you wanted the Hodgkin because that was the one that was actually potentially curable, which is why we separate it out from the other types of Hodgkin's. The Reed-Sternberg cell, not interesting to you, but this is kind of the characteristic cell that is the actual cancer in Hodgkin lymphoma. There's a multitude of types of lymphoma, not so interesting. This, however, is. So we stage lymphoma differently from how we would stage say, a breast cancer. In Hodgkin's, it has to do with you have one focus of lymph nodes, that would be stage 1. If you have lymph nodes in a couple of areas, that would be stage 2. If it's above and below the diaphragm 3, and if it's out in an organ other than the lymph nodes, like the spleen or the liver or the bone, that would be stage 4. And those of you also know you were staged as A or B. So B symptoms are fevers, chills, night sweats, weight loss. And A is the absence of those symptoms. So knowing what the stage is, particularly for patients treated many years ago, allows us to predict what the radiation was that they would get, right? So no point in giving a lot of radiation below the diaphragm if your disease is localized up here. But interestingly, and I'll just show this quickly, our survival rates have gone up and up with Hodgkin's, which is good. But interestingly, we didn't have CAT scanners back when many of you were diagnosed. So that's why you had to have a staging laparotomy. We had to literally open you up to decide if you were a stage 1 or 2 or a stage 3 or even a stage 4, because we simply couldn't tell just by looking at you. X-rays weren't sensitive enough. So it really wasn't until the 80s that we started having CAT scanners that were good enough to show us the extent of disease in Hodgkin's survivors. I didn't get the commercial, but I am a wildlife photographer and I'm not playing doctor, so I can't help but put them in to change slides. So this is a yellow warbler for anybody who cares. All right, so what is radiation? Well, radiation, this presentation is brought to you by radiation, right? You're looking at me, you're looking at light energy, you are looking at photons, and we're equipped to be able to process those photons, send impulses to our brains so that we can interpret them. So radiation is energy, a big part light energy. Protons, which you may hear, I doubt any of you were treated with protons, but you never know, are a different type of radiation that we use in clinical medicine these days. And I find this it's interesting. So photons I liken to a bullet, and many of you might have had cobalt radiation. different ways of generating the radiation. And a photon is like a bullet, meaning you fire it from the gun, it hits a peak energy right at the muzzle, right? And then as soon as it hits the air, it starts dropping in power. And if it hits a target, hits a tree, that energy gets absorbed into the tree. That's how radiation works. So you have a higher entry, and then it slows down as it goes into your body. And that explains some of the weight damage, because you think of our body, we're basically a pyramid up here. So these upper nerves might get more damage than stuff that's further down here, all else being equal. Interestingly, photons, which we use, or protons we're using a lot more in radiation, are like a torpedo. They're fired with a certain energy, and then they release all of their energy at a target. And that's one of the new radiation technologies. Still has issues, right? So I see a lot of head and neck cancer patients, particularly who are treated with protons. And I've seen some of my worst radiation injuries in those patients because for some reason they think they can get away with giving slightly higher doses. And unfortunately, a lot of important stuff is exactly in the target zone where this radiation is going. Your dose of radiation is important. And when I ask most patients, they'll say, I got 6 weeks of radiation or 3 months of radiation, or they might say 35 treatments of radiation. That doesn't really help me. The information that I really want to know for radiation is what your total dose was and what the size, and either the number of treatments or the size of those treatments. But the single most important number is the total dose, which ranges in Hodgkin. I see it as low as 2,800 centigrade or rads, which would be 28 gray, to as high as like 45 or 50, which is a fine dose for like breast cancer, but when you're giving it to these big, huge fields, I'll show you in a minute, for Hodgkin, it can cause a lot of damage. So, and unfortunately, a lot of these records are lost, right? Some of you were treated back, in the 60s, 70s, 80s, 90s. The doctors since, retired, and that hospital has been absorbed by somebody and all the records were lost or not digitized or whatever it is. So I get that, but it is very nice for me when I can have the radiation dose, because one, it's just, you still have radiation fibrosis, but it helps me kind of predict what's happening. And also some people get a boost, like you get radiation to this and then you get a little extra right here. And that also sometimes helps me predict what's going on. So just kind of the relationship, total dose is how many, rads or gray of radiation you would get. The fractions is, like the bricks used to build that wall, if that makes sense. There's also different ways we give radiation, and this is more important for what's happening now. Back when many of you were being treated, it was we radiate you from the front, we radiate you from the back. We might use some blocks, and I'll show you a picture of one of my favorite pictures a patient gave me some time ago to sort of illustrate that. Nowadays, we're able to do much more in-field or conformal radiation, meaning you guys remember Ghostbusters when they had to kill the bad thing at the end and they crossed the beams, right? All the beams converged and all that extra energy destroyed the bad guy. Well, this is sort of what we do in conformal radiation. You have beams coming from multiple directions with different intensities. We can call that radiosurgery sometimes, intensity modulated radiation therapy. But the idea is it's just a much more sophisticated way of using our CTs and MRIs and bringing the radiation from multiple directions to really hit the target. The beauty of this is in Hodgkin's, you do it for like just a mediastinal tumor. You could do it with minimal damage now to the other surrounding tissues, where before everything got the same dose. We didn't have a meaningful way to sculpt the radiation. So that has been a huge improvement as we've gotten better. All right, Brewster's Warbler, for anybody cares, it's a hybrid. All right, so what is radiation fibrosis? What is radiation fibrosis syndrome? So when you hit tissue, any body tissue with radiation, enough radiation, it damages that tissue. And we call this the gift that keeps on giving. The radiation's out of your body, just like when we finish the Zoom call, the radiation's out of the room from the TV you're watching. It just goes, gets absorbed, new radiation comes on. But the damage to the DNA causes the cells to misbehave. And when those cells start misbehaving, among other things they do is they start putting fibrin, which is a normal protein building block of your body, and they start putting it in places where it shouldn't be. And the tissues start getting hard and fibrotic like a scar. So we call that process from radiation that can occur, forever, radiation fibrosis. Radiation fibrosis syndrome are all the bad things that happen to you as a result of the radiation fibrosis itself, if that makes sense. So, the radiation fibrosis underlies the radiation fibrosis syndrome and all of the issues that you can get as a result of it. This happens over time. Starts initially, you really don't see much of anything, maybe a little chronic inflammation, to later you just get these sheets of fibrosis that have really no viable living cells in them anymore. And this happens at different paces in different people for reasons we really do not understand. The things that determine your severity of radiation fibrosis are the total dose, which is huge, but also the size of the fractions. If the size of the fractions of each individual treatment we gave you were very high, that can be very damaging to the tissue. Now with these new radiation techniques, we can give very high doses that were unheard of before because we can sculpt it to just that target of the cancer. So for instance, if you've ever heard of gamma knife or cyber knife for brain tumors, that's a way of giving a very high dose in like one treatment. So the dose, the size of the fraction, other treatments you've had, the chemo, surgery, everything else can kind of contribute. Your overall health, I say protoplasm, basically, do you have bad diabetes or arthritis? That would contribute. The tissue type, I will show you that. Not all tissues have the same susceptibility to damage from radiation. So for instance, the lungs effectively melt if you give them too much radiation, where bone is relatively resistant. Believe it or not, nerve is relatively resistant to radiation. And then the X factor is time. This is the gift that keeps on giving. So radiation that might have had no clinical manifestations, you thought you were fine for 5, 10, 15, 20 years, later you start noticing that you're having severe progressive issues. And there's no stop time for this. This process goes on like old age forever. It never really slows down. So this is just for breast cancer, but it's kind of illustrative. If we get 50 gray and 2 gray fractions, our nerve risk, damage risk is very low. But if we go up on the size of the treatments and the total dose of the treatments, you start really having a high risk of nerve injury as a result. And this is just showing the relative sensitivity. So, joint and bone, brain, believe it or not, and nerve are actually very resistant to radiation. But again, it's that X factor of time that causes the manifestations to have. Lung, kidney, liver, notoriously sensitive to radiation, which is why we try to shield the lungs back in the olden days of doing this radiation to try to minimize risk. That being said, parts of the lung are still in the field because we weren't that good at it, and they can become damaged and fibrotic as a result. So these are the fields. Because this is a Hodgkin's lymphoma, our targets were largely the lymph nodes and the lymphatics. And there are many different fields that patients may have had. Good for you to sort of understand this. The most common is what I say here, the mantle field. Everything from the back of your neck, right? You'd lose a hair on the back of your head, your neck, your armpits, right? Because there's lymph nodes in there. And the mediastinum would be radiated. That's far and away the most common type of radiation we see. If you had some disease, or we didn't know if you had disease, below the diaphragm, then they might do the para-aortic lymph nodes, and that's called the splenic pedicle there. And if you did mantle and para-aortic, we called that subtotal. It wasn't quite total, it was just subtotal radiation. If we did the para-aortic and the ilioinguinal, that's called inverted Y, hopefully for obvious reasons, it looks like an upside down Y. And if we did everything, which I know many of you have had, we call that total nodal radiation, radical lymph node irradiation. That has a number of other diseases. But your problems, which nerves are going to be damaged, which structures are going to be damaged, obviously is based on what got radiated. Because one of the rules of radiation, it damages stuff that's either in the radiation field, the areas where we radiated, or that are coming through the radiation field. So this is just showing you some real life. Here's the Hodgkin's. These are being, mapped out in X. And all of the rest of this is going to get radiation, right? You can see 25 to 45 centigrade or rads of radiation. Here's another one. This is now more involved field. This is using these conformal, new, more sophisticated techniques, right? Because we can see now, without having to open you up with our CAT scans and our PETs and all of that, exactly where the affected tissue is for the most part. We can just target that tissue with hopefully minimal damage to other parts. So you're going to get some lung in here, but all the lung out here is going to be fine. Your liver is going to be fine. Your intestines are going to be fine, right, in a patient radiated like this. And these are those pictures I showed you. If you're out there and you gave me these pictures, thank you. These are, to me, just so illustrative. You know, a lovely young woman here staging laparotomy, and you can see how they've marked her up to be shielded with the radiation front to back. But you can imagine there's still quite a bit of lung up here in the top that's in it. The heart is in the radiation field, the spinal cord, the nerves coming out of the spinal cord, everything else those connect to are obviously in the radiation field. And this little piece of whatever that is, plaster here, is probably what I believe they were using to block, right, the radiation hitting the lungs. But again, very crude. This is from 92, and it's still pretty crude. All right, so this is something that I just published. Anybody who's one of my patients up to about, a few months ago would have been included in this study, de-identified, of course. So this was just a retrospective look at 100 Hodgkin survivors I have, talking about which specific issues are affecting you. And this needs to be done, I think, now in a prospective way, meaning, instead of looking back, looking forward to do a better job, because I think we underestimate something. So damage to the spinal cord. And I'm not talking about you being paraplegic, but I'm talking about just damage that I can see clinically when I examine you, which I can go into if you want, if you're interested. But more than 80% of patients have some spinal cord damage. Damage to the nerves coming out of the spinal cord and in the shoulder, called the plexus, the brachial plexus, also the lumbar plexus. Again, huge, like more than 90% of you will have damage there. Damage to individual nerves, not the nerve roots of the plexus, but other nerves that have a name in the field. Again, 95%. And then damage to the muscles, more than 90%. That's why I call the neuromuscular damage a myeloradiculoplexoneuromyopathy. I'm simply naming the spinal cord, nerve roots, plexus, peripheral nerves, and muscles that are in that field. It's like naming, neck, shoulder, elbow, wrist, hand. There's nothing really that sophisticated about it, but it helps me sort of calibrate my radar for what's going on with you. Sexual dysfunction. I'm sure I've underestimated this. I need a questionnaire to ask more about it, but approaching 10%. Cognitive, I am quite sure people have cognitive issues. I think if we do an informal poll, once I stop running my mouth in this presentation, I think the majority of you are going to tell me you have some sort of cognitive issues. Trouble walking, at least 40%, but really probably much higher. Dropped head, that's one of the biggest things. People come to me when I was looking around at the group. I can see all of you braced up or propped up in various ways, and all the cervical atrophy so common in Hodgkin survivors, at least 80%. Neck pain, nearly 80%. Problems with the shoulder, 70+%. Trouble swallowing, it's dysphagia, 40%, probably higher. Trouble opening your mouth, right? Not super common like in my head and neck cancer patients, but present. Pain, fatigue, and trouble breathing, also extremely high, just in my patients. Now, remember, my patients are very biased, because you're not coming to see me because it's Wednesday. You're coming to see me because you have issues, and these are the sorts of things that I'm finding in you. Some of you may be out in the audience here. Hopefully you did give me permission for these, so thank you. But this is pretty classic, right? Early Hodgkin's, right? Mantle field radiation. You see all of the cervical and thoracic atrophy. The trapezius here is atrophic in everybody. The rhomboids, the rotator cuff muscles coming down to here. Nice gentleman who had total nodal radiation, and the whole neural axis has been damaged by the radiation. And then an older gentleman, just mantle radiation. But you see his issue here is cardiac as much as the severe dropped head syndrome. So visceral complications, meaning not nerve and muscle, but heart, lung, all of that, also extremely common in my patients, and these are probably underestimating. Cardiac disease, huge. 70% at least And so many of the patients have multiple cardiac impairments. I guess joke is the wrong term. I teach my residents that Hodgkin's can do everything to the heart except congenital abnormalities, right? It can damage the conduction system, the coronary arteries, the valves, the lining, the pericardium of the heart. All of those can be affected by Hodgkin's. And you see that valvular disease, 40% arrhythmia is very high. Coronary artery disease, that's probably a gross underestimate. Pericardial, the lining, outside lining, the sac that the heart's in is damaged, et cetera, et cetera. Pulmonary damage, again, probably an underestimate, but at least 40%. Low thyroid, very common. I think, if I poll you guys informally, I will be surprised if there's a handful of you who don't have thyroid problems. Bone thinning is very common. Trouble with GERD, like reflux, and slow moving bowels, very common. Again, all of these, because I'm really more of a neuromuscular, and this was a retrospective chart review, I know these are underestimates. Lymphedema, very common in the group. And then secondary cancers and cancer recurrence, very large in the group. Most common, because it's a lot of women, a lot of breast cancer. I'm going to screw this number up, but there's some statistic, like if you irradiated when you were younger than 20, you had like a 10-fold increased risk of breast cancer for Hodgkin's. And that's kind of what I've seen is so many of the Hodgkin survivors come in and they also have breast cancer. So the incidence of a second cancer at 40 years is, over 40%. It's very high. Cancer and cardiac disease are the biggest causes of, mortality. What's going to kill you as a survivor of Hodgkin's? This risk continues greater than 35 years. Again, when you look at statistics like this, you have to think that when we are gathering them, we may not have had 30-year survivors, right? A lot of this stuff is kind of old. Breast and lung are the most common cancers, and this is just a breast cancer on a mammogram here. So screening, which I think a lot of you may ask questions. There are guidelines for screening when you're working with your folks at home. Your internist or your oncologist who may or may not still be following you. There are certain things that you want to do to try to help ensure that either you don't get something or you do get something that we can treat it early. It's almost universal that treating cancers and heart disease earlier is better than waiting till later. So breast cancer, we start the screening earlier. We do use breast MRIs. The data on exactly when to do this is not clear, but the point is pretty much everybody I saw on there should be having regular mammograms or breast MRIs, right? Lung cancer, another, I said this is a big risk. So basically computed tomography in the chest 5 years after diagnosis, particularly those with a smoking history. I have not been doing this routinely, but if you're a smoker, then I think it's absolutely reasonable that, you should be getting chest CTs. Skin cancer check. This is very common. Like, the radiation causes a lot of skin cancer in Hodgkin survivors, and those are treated, curable for the most part if found early, except for, melanoma. Even that, again, if early. Colon cancer, starting your screening 10 years. It's 50, I think they moved it to 45, so now 35 would be the thing. So most everybody I saw on the call should be having regular colon cancer screening, particularly if you have total nodal radiation, meaning the radiation involved your bowels. Cardiac disease. This is, the big killer. So many of the patients, so many of you folks have cardiac disease, that regular echo, stress tests of some sort, EKGs, and following with a cardiologist who understands radiation late effects. The treatments are very similar. If you have radiation and Hodgkin's and heart failure, the treatment's the same for somebody who has another reason for heart failure, but we still want to follow you closely. And then, of course, if you're smoking, you're overweight, you have high lipids, you have high blood pressure, we want to control those as well as possible. Any other things, I'm always listening for carotid bruits and ordering carotid Dopplers and looking for other things. If possible, respiratory. I try to get a baseline pulmonary function test on all of my patients for the most part. And again, it just lets us know how badly the lungs were damaged. And if you start getting short of breath or start getting other issues, we don't know if it's your lung or your heart. So having this baseline PFTs may help us know what's going on with you and be more effective in our treatment. So it's a relatively easy, cheap, safe test to do. So I kind of like everybody who walks through the door to get one, and I prefer for patients to be followed by a pulmonologist who knows more than I do, same with a cardiologist about these issues. Hypothyroidism, again, easily cured with thyroid medicine in most patients. Some it's a challenge because bowel absorption issues. Diabetes, again, if you have it, we try to control that. All right, the golden winged warbler for anybody cares. All right, so we're moving into the end here. I'm not going to go exhaustively through treatment. I figure there's going to be a lot of questions that we can talk about some of the specifics of what needs to be treated, what you can expect from treatment, and where you can find treatment, which is very important. The majority of what I do, again, I'm kind of a survivalist in that I'm taking care of, in some of my patients, all of their survivorship issues of Hodgkin's, and because they don't have anybody. Others, I try to share them with people who are more knowledgeable about, say, the heart or the lungs than I am, even though I'm an internist. But on the rehabilitation side, there's multiple spheres, right? There's rehabilitation physicians, that's me, physical, occupation, and speech language lymphedema therapists, preferably those that have extra training, knowledge, and experience in managing Hodgkin's. You are one of the toughest groups of cancer patients to get optimal outcomes in. And then, of course, oncologists, neuropsychology, cognitive rehabilitation, and basically everybody is and should be a partner in getting you to your highest possible level. Again, we're not talking about curing people, but we are talking about optimizing your function and quality of life. So therapy, physical therapy in particular, and I'm just using the dropped head syndrome here as a result. For those of you who have dropped head syndrome, your shoulders go forward, your neck goes forward, you have all of this cervical atrophy. Because the lungs were shielded, these muscles tend to be very tight and pull you forward. Your core tends to get weak. So a lot of work on what we call, patients say, oh, I'm getting massage. Well, what you shouldn't be getting massage, what you should be getting is myofascial release, which is these long hold, trying to get a gymnast to do the splits sort of thing, where you're trying to take those tight tissues, right, and get them to start slowly over time stretching, so that you can get your shoulders from here into more of their upright and locked position, and then your head will go back. That manual myofascial release done properly is one of the most important modalities that a therapist can offer you. In addition to that, neuromuscular re-education, right? The nerves, even if they're working a little bit, they still need retraining, right? To try to do as much as they can in terms of holding you in the proper position. Some people, they literally don't know. One of the things, again, it's like the Austin Powers, sharks with lasers on the head. We'll put a little laser on the head, trying to write their name with it. They can't. They have no proprioception. Even if they have the strength, they just can't tell where their head is in space. So that neuromuscular re-education becomes important to reset your knowledge of where you are in space. Strengthening the core is important. Balancing the muscles is important. Postural retraining is important. There are a number of modalities. And again, you could be the best sports medicine therapist in the world, but if you don't have experience with Hodgkin's, a therapist probably is not going to get optimal results. For patients who have pain, and I treat a lot of pain, my preference is to start with nerve stabilizing agents like pregabalin and gabapentin. That's Lyrica and Neurontin, respectively, duloxetine, which is Cymbalta. I do have a number of patients where I'll use actual opioids to treat them. And then I already see a lot of you with collars. There is no one best collar. The best collar is the one that you like. There's a lot of designs out there. I don't think anyone is particularly good. The Headmaster is kind of specifically designed for drop head syndrome, but the problem is it hits the collarbones, it hits the sternum, it hurts the chin. It's not terribly comfortable for most people. So I actually did do a study on it. There's a huge rate of discontinuous use of the patients that I gave this to. And most of them, would only wear it 0 to 3 hours a day, which is fine. Most of them modified the collar. They would use it for and I'll tell patients when you're watching TV, doing things around the house, but they use them in other situations, particularly like when you're in a car being usually driven around as opposed to driving. And there are a lot of reasons to discontinue, right? It's just uncomfortable, it hurts, it's not good. I've been suggesting more what we call semi-rigid collars recently, which you can get off of Amazon for less than $20 often. Pain management, again, we can talk more about this, but it's really very much a multimodal activity. There's no one magic bullet. For me, it's going to be therapy. It's going to be medication for those patients who will benefit from it. It's going to be bracing sometimes. And just talking about resources, so, it's no secret that since I left Sloan Kettering for Select Medical is this big rehab company, started in Pennsylvania. We've now got, I don't know, I think 16 or 1,800 outpatient therapy facilities across the country in 40 some odd states. We've got 100 long-term acute care hospitals, and we have 30 some odd rehab hospitals like Kessler, Cleveland Clinic's Rehab Hospital, Baylor, Emory, Cedars-Sinai, UCLA, Penn State, Hershey. So we're a pretty big company. So I'm here with the goal of creating comprehensive cancer rehabilitation services across our network. Now, this has been going on since I've been there in 2015, and we're doing pretty well. We're not everywhere. Our quality is good, but our therapists can always be better trained. It's been a Herculean lift, but it has, a couple of chats, brought, reasonably good, if not superb, cancer rehabilitation services to a lot of you. We spent a lot of time on education because you don't just wake up one day understanding how to treat a Hodgkin survivor and get the best outcome. It takes constant ongoing work. This is our website, revitalrehab.com. If you want to see if there's a location next to you, just click here and type in your zip code. I just got this today to kind of show where we are. Again, not everywhere, but we're in Alaska and Maine, Washington, California, a lot in the Midwest, here in New Jersey, Pennsylvania, Virginia. We've trained well over 1,000 therapists. We're treating 1,400 plus patients a month. We've got 440 plus centers. That's growing constantly. We're in 21 markets in I don't remember, nearly 20 states. All right, so with that, thank you. And I will stop now for questions. This is, somebody's gonna ask how to make a visit with me. This is my assistance line. So those of you who wanna drop that down, 973-243-6938, and I will stop sharing. So now we can start talking questions.
Brilliant. It will help if I unmute myself. Thank you so much. That's been quite a romp through Hodgkin's history and the treatments and so on, but I think really helpful to have all of that background. So we've got a lot of questions that have popped up in the chat, and I'm going to try and feed you some that I hope will be helpful and useful for you. Can I ask everybody else to stay muted, please? Muted. Oh. Everybody else, please stay on mute. If you've got questions, please pop them in the chat, and I've got my other team members are watching that for me and prompting me so that hopefully we will ask the right ones. Various people I think have asked about diagnosis codes. Is that, Kathy? I'm not quite sure what was meant by that.
Meaning, is there any special code to get therapy for Hodgkin's?
Yes, that was it, and really to kind of inform your doctor that this is what you need and what you're looking for and how it gets covered, and things like acupuncture or other therapies.
Okay, yeah, thanks, Kathy. Good question. So there's no specific code for radiation fibrosis syndrome. There is, however, an ICD-10, and you can just go on and Google. ICD-10 is our new kind of coding system that has, it's not as comprehensive as you think, even though it has things like sucked into jet engine to a visit, right, as codes. I'm not joking. That's literally some of the stuff that's in there. It's quite funny. I use radiation late effects. Personal history of radiation is two of my common codes that I'll code a Hodgkin survivor with. Then I will code other specific impairments, right? So I'll code cervicalgia, meaning neck pain, dysphagia, trouble swallowing, shoulder pain, whatever it happens to be. And then for things like myeloradiculoplexoneuromyopathy, which I kind of mentioned before, I'll put that in a notes field in the Epic system that we use, right? I'll kind of explain what I mean by that. So there's no specific code for what you have, and you have to understand it's a syndrome. So there are multiple individual things that you can have, all of which should be covered for treatment by insurance for the purposes of seeing your doctors and getting physical occupational therapy, right? And it really just depends on what your therapy coverage is. I hope that helps.
Thank you. Great. So the physical rehab side of it, I think a lot of us are interested in that. I know for a fact there's a number of other people within the present company, including myself, who work quite hard on keeping ourselves as fit as we can, core strength building, which you've mentioned. Yep. Some of us have been lucky enough to find physiotherapists or other therapists who can do myofascial release. Presumably this is just basically a lifelong project now. We need to keep going with these things. Would you like to elaborate on that at all?
Yeah, I think you're as much or more of an expert than I am on that, but absolutely right. It's very much a lifelong endeavor. Radiation is the gift that keeps on giving. Even if you get up to a certain, you start here and you get to here, it's going to start dragging you back down at various speeds. We do not have a cure for it. There's no, somebody's going to ask, is stem cell transplant going to work? No, not at this point in time. So there's no cure. And so the fight is really kind of old school, staying fit, doing your stretches, trying to maintain your core, and trying to manage the things that are going to really cause issues like having a heart attack or a valve going out or getting a secondary cancer that we could have cured had we found it earlier.
Great, thank you. So keep at it, everybody. And if you're not doing it already, now's the time to start. Brilliant. A couple of people have asked about cognitive impairment and why might that be happening to people?
Yeah, that's a great question. I don't know. Is the short answer. I've been trying to get other people who know more about it at Kessler to try to enter into a study for it, because I think it's underestimated in the little thing I did, and I recognize that because I'm not screening for it nearly well enough. So there's things. One, having chronic pain can cause cognitive impairment. Having cardiac disease and lung disease can cause cognitive impairment. Being fatigued all the time in general because you have heart disease, lung disease, and damage to all of your nervous system and not able to walk, it can cause it. So I don't know if there's any one answer. I think it's a multitude of things ganging up on you, including the fact that we're getting older, right? So as we get older, we lose a bit of cognitive impairment, cognitive function anyway. But I do think this is a big magnifying glass on it, making it bigger. That being said, I have no idea what the actual, if there is one single thing, which one's more important. And other than doing sort of cognitive rehabilitation and making sure your thyroid function is normal and controlling the things that it can control medically, that there's any single thing that's gonna unwind that for you.
So multiple reasons why we might be having a slightly increased rate of cognitive impairment over and above what we might be noticing as we age anyway, really.
Exactly.
Worth looking out for anything that might be treatable or reversible, I guess.
Exactly, yeah. When somebody comes with that, it's always worth, making sure that your calcium, right, isn't running at 12, right, because you have primary hyperparathyroidism or something. So there's medical things that we should look for, which most physicians, GPs, will be able to screen for. And once all of that is negative, we're kind of left with a shoulder shrug and treating it empirically, because we don't have any certain way to cure it.
Yeah, okie dokie. Radiation fibrosis syndrome. So I think people want to understand more about it, and whether that's what's giving them symptoms, and is it when the tissues look atrophied, is why I'm pointing to my neck, because of
Yeah.
course that's where I got it, and all around this shoulder, to the point that my physiotherapist, who's got to know about it through me, said, I went away last week and there was a guy in the group who'd had Hodgkin's when he was in his early 20s, and I could tell by looking at him because he got the same changes. So those changes are presumably occurring because we've got fibrosis replacing normal tissue and it's not as bulky. Is that correct?
Yeah. So again, the sort of pathophysiology is that when you get radiation, it causes changes, among other things, in the DNA of the cells that were in the radiation field. Those cells start misbehaving. One of the things that they do is they take protein called fibrin, which is just a little microscopic, smaller than a cell, brick, if you will, and it starts putting it in places. It's a normal tissue, but it'd be like I start filling it with bricks. Pretty soon I'm going to die in the room because it's filled with bricks. So those tissues that have all that fibrin in it start getting too far from the blood supply and they die. So initially, like in some patients, you'll get atrophy. You'll actually get hypertrophy, bigness of the tissues, and then later it just starts shrinking. And that's what's happening to the muscles, but also to the nerves, to the tendons, to the ligaments, to the blood vessels, to the skin, to every tissue that was in that radiation field to various degrees based on the individual sensitivity of that skin. So that's why everybody ends up with, you know, the small neck, but it's also stuff that's outside of the field can be damaged. So for instance, your bicep muscle, right? Your bicep muscle gets its root innervation coming out of the neck at cervical number 5 and cervical number 6, going through the upper trunk of the plexus, gets out of the radiation field. But you'll see patients who have atrophy of the biceps because that nerve is traveling through the radiation field, if that makes sense. So there's the direct effect of anything in the field, and then the indirect effect of muscles that would get their supply by traveling through. And that's very common in like plexopathy. So I have patients who, you know, they can't open or close their hand. It's just, you know, floppy from the radiation.
Excellent, thank you. And staying with radiation fibrosis syndrome, really, and what's the overlap about that with kind of fibromyalgia and chronic fatigue syndrome?
Yeah.
Is there an overlap, or is it misdiagnosed as one or other of the other?
Yeah, that's actually a great question, right? So many of you have been told that you're crazy. I get that a lot. Doctor has no idea, thinks I'm looking for drugs. Or the most common one is to say you have fibromyalgia. So fibromyalgia, and you may, on top of this. So let me explain what fibromyalgia is. We used to think of fibromyalgia as a rheumatologic condition like lupus or rheumatoid arthritis or other things like that. Now, the problem is there's nothing actually wrong with the tissues in fibro. You go and you biopsy the muscle that hurts, the normal muscle. The problem in fibro is actually a central nervous system problem. It's a problem of what we call gates. So we'll do a little experiment here, and forgive me for being a little crude. How many of you can feel your right butt cheek right now? You're all sitting down. Concentrate on the butt cheek. Think about it a little bit. Pretty soon, you're all going to start shifting in your seat because you're thinking about it, so it starts making it uncomfortable. So as we sit here, the gates in our central nervous system are making us, shift and do stuff and move around so that we are, without it raising to our consciousness, avoiding what we call noxious stimuli, things that feel bad, right? And that's just how we're programmed, because you can't be thinking about every little noxious stimuli that comes to you. We'd all go literally insane. So those are all cut off at the spinal cord level. The problem in fibromyalgia is those gates that would control your ability to have pain signals come through aren't working properly. They're leaky, so that any pain you have gets magnified above where it would be. The tissues are normal, your perception of it, and it's a real thing. Nobody's faking it. Now, fibromyalgia is associated with things like depression and anxiety, right? Depression and anxiety also associated with being a Hodgkin survivor. It's associated with chronic illness. It's associated with cancer, associated with breast cancer and survivors. It's a very common, but really, I think, understood disorder. So it is entirely possible that you have fibromyalgia, those of you who are out there, but it would be a sort of add-on into your radiation fibrosis syndrome and would be a magnifier of the pain symptoms that you have from radiation fibrosis syndrome. And chronic fatigue goes back to the cognitive issues, right? Your brain is not able to connect to your body because all of the radiation damage to all the spinal cord and the rest of the nerves. Your heart isn't working right. Your lungs aren't working right. You're going to be fatigued, right? So that is a very common symptom in radiation.
Thank you. Thank you. So it's complex, isn't it? And there is...
It's all complex, yeah.
You know, actually, probably quite a lot of us do have an element of fibromyalgia for all those reasons, as well as radiation.
Exactly. That's right.
Okay. Can the liver and pancreas get damaged from radiation? People.
Oh, absolutely, badly. Yes. Yeah. So if they're in the field, then absolutely. The liver, if you remember that slide I showed, is one of the most sensitive. Now it has more capacity to regenerate itself, but absolutely the liver will melt given enough radiation.
Mm-hmm. Mm-hmm. So that's for people who've had below the diaphragm radiation, obviously, really.
Yeah.
Not mantle field, probably not going to get enough scatter there.
No, it's not. In the olden days, we weren't that good, right? I mean, this was carpet bombing with radiation. This wasn't a precision strike. So if you were radiated back in 1970 or 80 or earlier, you know, even the 90s, it was pretty barbaric stuff. I showed you the woman. I think those pictures were for 92, right? There was a lot of scatter that, you know, you just think of the spillage of light. If you were to, you know, just a pinhole, there's a lot of spillage around of the radiation. So no, things will be in the field. Usually the damage to the liver and the pancreas would be more acute, but absolutely, if there's fibrosis in there, that can potentially happen later. It's not one of the biggest issues I see, though, either of those in survivors.
Okay, thank you very much. So yes, it could happen, but it fortunately doesn't happen very often.
Right.
I'm looking at radiation fibrosis again, as someone who's saying that they were told they couldn't have it because stretching and clicking helped, and that she'd previously been told her ribs were hypermobile because everything was becoming so rigid they were being pulled out of place. That sounds like a load of baloney to me. What do you think?
Yeah, baloney. Like whoever said that, don't see them anymore. Right. You know, so what happens, because your chest wall is in the field, it gets fibrotic. It gets, you know, your ability, you get a restrictive lung disease because of the lungs themselves and the bellows, your chest wall. So one of the things our therapists do is they get in between those ribs and they massage and teach you a lot of deep breathing exercise, trying to slowly stretch all of that out again. So I have no idea what they were saying, that doesn't make sense to me.
Doesn't make sense. No, I agree. It doesn't make sense to me either. Okay. So influences on nerves. So somebody's mentioned tinnitus. Can that be a problem from radiation of cranial nerve? Mm-hmm.
Yeah, absolutely right. So it just has to get your optic nerve in there. And you know, again, the radiation's pretty scattered. So a lot of you will remember they radiated you kind of like this. You lost on the back of your hair. So your ear is right there and actually sits down below that. So it's not uncommon to get hearing loss and that. And also some of the medications they use may have caused some damage depending on which protocol you were on.
Sure. Yeah. Chemotherapy damage. Okay, cool. And vagus nerve damage?
Vagus nerve, absolutely. Any nerve in the field. So the vagus nerve is very commonly damaged in radiation. So we see decreased gag, but we also see, you know, autonomic instability. One of the things I didn't talk about was baroreflex failure, which is from damage to the carotid baroreflex, which will cause your blood pressure to shoot up, crash, or heart rate to shoot up and crash. It can be really very, you know, debilitating, but absolutely vagus nerve is phrenic nerve, vagus nerve. You name a cranial nerve, it can be damaged by radiation, you know, and again, it's just where it is, right? Your optic nerve, less likely to be because it's higher, but once you start going south of them, I've had, you know, like a Duson's palsies from cranial nerve 6 damage, you know, there's you know, all of it's common. Temporal mandibular joint problems, fairly common.
Mm-hmm. I think a lot of us have autonomic dysfunctional problems with heart rate regulation and blood pressure regulation, either just going about our everyday business or if we want to exercise. I think it's quite a common problem, isn't it?
It is, and woefully under-recognized.
And difficult to treat, really.
And well, that's also right. And you know, the problem is when you're getting symptomatic, you're passing out from the low blood pressure. We have to control for the floor so you don't hit it, right? But that may mean that at other times you're up into so high you're getting headaches from it, and it's not good for your heart and your, you know, other blood vessels. You know, so it's there's sometimes no good pathway through.
Cool. Slight switch of tack, thinking about breast surgery and reconstructive breast surgery here, because you've said it's a common problem, and I know a lot of the women and at least one or two of the men who have attended some of these have had breast cancer problems. What about reconstruction? So, for instance, traditional Latissimus dorsi reconstruction, is that maybe not very clever given all of the chest muscle problems that we're getting from radiation?
Yeah, that's actually a great question. So the answer is I don't know. I don't want to tell a woman that she can't be reconstructed because there's so much psychology around there, but certainly there is a lot of potential issues that can happen with the reconstruction. So the implants going to, you know, tissue extender implants, those are hard enough in normal, you know, unradiated women. But, you know, I've had a number of Hodgkin survivors who've been reconstructed where that's not their issue. But it's a little bit of a rolling of the dice. And I can't really, you know, say one over the other. A lat flap would probably be my least favorite because shoulder dysfunction is so likely to be impaired. That being said, so a latissimus dorsi flap, they'll turn it around and reconstruct the breast mound and often put an implant with it. A transverse rectus abdominis flap is another one where they take skin, fat, muscle from the abdomen and use it to reconstruct. Either as a free flap or a pedicle flap, so it's still connected to its blood supply. And then there's like a deep flap, which is deep inferior epigastric perforator flap, where they leave the muscle but they take the little blood vessel, but they're prone to fail in the best of times because it's hard to make that microsurgical anastomosis and it may not stick. So if you already have vascular issues from the radiation, and then we do one of these reconstructions on you, there's a higher risk, I think, for failure. That being said, I don't know of any data for it. I haven't really looked, but I don't know of any data. So that's a great question, though.
Cool, thank you. Yeah, so it's a tricky one, and I guess it's very individual, isn't it? Depending on how the woman's been affected by her radiation.
Yeah.
And mentally and psychologically, how she feels about the whole process as well.
Yeah.
Complete switch of tack to COVID boosters for a moment. Do you have any thoughts on getting a third booster for COVID?
Oh yeah, absolutely. I would have had mine yesterday if I could have. So I'm just waiting for the clock to tick out and I'll get it. And I don't think I'm immunocompromised. Every one of you should get it. Like that's just a no-brainer. It's pretty clear that our immunity is waning. And we're probably going to be stuck getting, you know, COVID, I think, has a very high likelihood of becoming the common flu, right? Where it's going to be not eradicated. We may or may not get different variants. So it's probably going to stay endemic in the population across the world. Even if we wipe it out in, you know, the United States and Europe, we've still got Brazil and all these other countries where they're not able to. Those are just incubator for new variants. So I think we're all going to be stuck getting immunized for it like we do for the flu periodically. But the good news is I think it'll be, you know, getting back to some semblance of normal life, just accepting that risk. For you guys, because you're all immunocompromised, you know, largely if you're a Hodgkin survivor on this call, to varying degrees, you all have potential cardiac and lung issues if you had mantle radiation in particular. You know, I think caution is warranted, you know, not excessive caution, but certainly caution, particularly until we know more. And it also depends on where you are, right? I'm here in New Jersey. We're in a condo. I'm not wearing my mask in the hallways. Maybe I should be. But our rates of infection here are really low, and like 85, 95% of the people in my city have been vaccinated. If we go to anything in Manhattan, also very heavily vaccinated, but, you know, if we're in public, we'll wear a mask. So it's really just, you know, using a little bit of your knowledge of what's going on around you.
So get the jab and carry on being careful.
Yes, absolutely. The risk from these vaccines is, we're not even in the same planet, right? So just to give you kind of the stats, and I just don't think the press has done a good enough of it. So let's say your risk of dying from a vaccine was 5 in a million, right? Sounds terrible. Oh my God, 5 in a million people drop dead from the vaccine. What do you think your risk of dying from COVID is? Approximately 18,000 in a million. So does somebody want to do the math for me about how many fold higher a risk you would have of dying from COVID than dying from the vaccine? And it's not like you get COVID and it's one and done. It's like, oh, I got COVID, now I'm fine, let's go back. Look at me, I'm so lucky. No, so many of these things have long haul symptoms that you guys are all experts about that will be Hodgkin's light for a lot of them, or bad pulmonary problems, musculoskeletal issues, cognitive issues, all of the stuff you're dealing with. A huge percentage. It might be a significant percentage of the millions of Hodgkin of people who've got COVID who get this, who are going to have long-term symptoms, and for some of them, I suspect they're never going to go away. So it's not trivial. Like any risk that you have from the vaccine is just trivial compared to the risk of getting COVID and even surviving COVID. So anyway, I'll get off my high horse now, but you did invite me here to be on a high horse, so there's that.
Well, as a primary care physician, I couldn't agree with you more. I think it's a no-brainer, really. Unless there's a serious allergic reason to not get it, you should get the jab. And I absolutely agree with you. Yeah. So I'm going to join you on the high horse for a moment.
Oh, perfect.
Lots more questions still rolling in. I'm thinking, someone's saying be on your high horse, full approval. So there you go.
Thank you.
You got the thumbs up there. Somebody's asked about teeth issues, which I know that we've talked about in our UK Hodgkin's International Zoom sessions. On one we all talked about all the teeth problems we've had. Could that be related to radiation? And of course the answer I'm sure is yes, but would you like to expand on that a little bit more?
Yeah, so right, your salivary glands were in the field for those of you who got it. So over time they get fibrotic. You get what we call xerostomia, fancy name for dry mouth. That becomes an issue. The fact that you have radiation to the jaw, even though the bones and teeth are relatively radio-resistant, they're not radio-resistant. And over time, you can start having avascular necrosis, loosening of tooth, caries, and all sorts of issues. So no surprise at all there. It's head and neck cancer patients, right, where they get higher doses to exactly that area are just, it's one of the most common things we see are just huge life-altering dental issues in this population. So yeah, there's no surprise there. And what's the treatment for it? Well, trying to use, sialagogues, things that help, if I say lemon, you should all start salivating. If I were to pretend to bite into a lemon, that helps. So you need to use things that try to keep you salivating. Good oral hygiene is also very useful. Seeing your dentist regularly, getting regular cleanings, et cetera, et cetera.
Yep, and high fluoride toothpastes, maybe if you're next to your high fluoride area. And I know a number of us use mouth guards at night to stop us from grinding our slightly too delicate teeth together as well, which can be helpful, I think. So I'm thinking about, someone said, could you please move back to New York?
I'm right here. It's like literally 2 miles that way. I'm not that far.
I think they want you to be working closer there, maybe. Are there specific carotid studies that you would recommend for follow-up?
Yeah, carotid Dopplers. So if anybody has a bruit, meaning we can hear the blood squirting through the carotid, then you should automatically get one. And I have no issue with you just getting one anyway, like you get an echo, because you're at risk. Head and neck cancer patients in particular, because they get higher doses, frankly, than you got. They get stenosis, narrowing of the carotids all the time. It's a risk for you guys. So it's just worth getting a baseline Doppler, and it's nothing test. It's what we do to look at babies. It's, just sound and not going to hurt you. And they're cheap.
Back to musculoskeletal stuff again. I think there's a few things here. I don't know if I can conflate them. I'm trying to see if I can mush them into one bigger question for you. People are asking about, is it okay to have massage therapy? Is it okay to have chiropractic therapy where they've been manipulated, which I would be slightly less keen on personally? And are hot tubs okay?
Yeah. Yes, no, yes, or yes, maybe yes. So massage therapy is not going to hurt you, right? I mean, if just getting a therapeutic, gentle massage, not somebody sitting there doing this to you, is probably, just fine and makes you feel good, and that's good. Very different from the myofascial techniques we were talking about. Chiropractic, I don't have any real issues with chiropractic. Like the high velocity adjustments, probably not good for anybody, especially this group. That's just manipulating your neck, somebody doing sort of a cranial sacral-like thing where they're just kind of moving you around and trying to make your cerebral spinal fluid move. I'm good with that. That's most certainly not going to hurt you. So, caveat there. And then a hot tub, I have no issue with that. I think unless you have open wounds, you have some big infection risk, it's probably unlikely to do anything. If you have autonomic instability, like it's all very personal to you. Like if your blood pressure just can't handle you being in a hot tub because you passed out and drowned, should not go in a hot tub.
Yeah, I was thinking about autonomic problems in a hot tub. I can't go in a steam room without feeling lightheaded. So I think, someone's asking, mentioning that they've had a frozen shoulder twice. Despite being active and working out regularly. Is this radiation related? Yeah, absolutely. So your shoulder may or may not have been in the radiation field, but certainly the rotator cuff muscles that work the shoulder and the nerves that work in the shoulder with. So most commonly in Hodgkin's, the classic weakness presentation is, your neck's weak and atrophic. The deltoids, those of you who see me in clinic, I push down, right? And I always, if I have a resident by me, I go, look how weak they are. And I tell you there are 4 or whatever. That's very common. Everybody's weak there. Everybody's weak in the biceps. When you try to do resistance, I can pull them out. Triceps back here, keep your arms straight, better. Hands usually better to various degrees in people. But because the upper nerve roots and plexus that work the rotator cuff are damaged, your shoulders tend to get protracted, right? So, if I was looking around, everybody's shoulders are like this. So what happens is the rotator cuff tendon, this is the tendon, sits under a little arch. These are bones up here, right? And when that weakness happens, they go whoop, right here to the low part of the bone, and you hit it. So you get tendonitis very commonly, and that tendonitis can lead to a frozen shoulder. So it's a dime a dozen problem in Hodgkin survivors. And the treatment, I don't really recommend surgery for it, except in, some because there's really so much neuromuscular damage. I mean, some cases, maybe if there's a lot of arthritis, it's really trying to work to keep those shoulders back in their upright and locked position, which, as you already said, Tess, is a lifelong proposition. Especially now they're all in Zoom calls doing this. But I think to be encouraging to people when we say it's lifelong, you've got to keep doing it. Yeah, you can really see changes.
Oh yeah, absolutely.
And I know others have really seen changes from just carrying on, keeping on with it
over
years. When I used to lay flat on the floor on my back, I literally couldn't lift my head off the floor without lifting it. And now I can do a roll up in my Pilates class. So, and I'm not superhuman. I just kept trying and working at it.
Exactly
and
right.
Giving a decent physio. So various people are asking about, I've just got an eye on the time. We've got a few questions about the right sort of exercises for musculoskeletal problems. What are the top 5 things you would do for severe RFS? And a couple of people saying, what sort of exercises and things would be helpful, particularly bearing in mind that some of us aren't so good at breathing with or have heart problems and so on.
So I'm going to actually punt on that one, and I'll tell you why. So I'm the doctor, I'm not the physio. So I am so much more likely to get you hurt. And what I do understand, I recommend certain classes of medicines, or not medicines, of therapy interventions. It's kind of like saying I need my oil filter changed and telling them how to do it. I kind of assume that they're, going to know how to do it with the proper training. So that's one reason, is I just don't want to step in it. The real reason, though, is so individualized. Each one of you is going to have different issues. And the point of a really good physical therapist is they're going to be able to evaluate exactly what those issues are, and then to come up with a personalized set of exercises that's going to help keep you on the straight and narrow. So if I tell you to go do this 10 times every night, I'm almost certain to get you hurt. So my recommendation is you need to work with a therapist who is knowledgeable about this, who can guide you and adjust on the fly if the exercises are too hard, too easy, and progress you, just like Tess is clearly progressed, right, in terms of what she's doing. And then the other thing is to go back periodically, because you get bored, right? And there's many ways to do the same thing, and you want to keep it fresh and interesting. So I'd recommend that. The other thing, Tess kind of mentioned it, Pilates. So of all of the after therapy sort of programs that you can do working with a Pilates instructor, because it's a lot of core in-type sort of thing, seems to be the best tolerated and the most effective for the patients that I've worked with. And again, I follow what my really world-class therapist has said in terms of what to recommend, but I'm not going to do it myself.
I can completely understand that. I mean, and one of the problems that some people are posting about is difficulty getting funding in the States for their physical therapy and myofascial releases because they haven't made enough progress or it's need long term. It's a problem in the UK as well, where everything is to be. The National Health Service doesn't offer long term therapy for people like me. I pay to get my physio, and not everybody can afford to. But I don't know if there are any tips for sort of how to get insurance to pay in the States.
Yeah, so right, that is a problem. Insurance is not, and I'm not sure they should pay for you to have therapy once a week for the rest of your natural life. The idea, because we just don't have the resources for that, to be honest. So the idea is we make you what we call an independent self-manager. So a good therapist there's going to be a lot of hands-on manual work that only they can do. They're going to teach you exercises, and they're going to send you home to do those exercises, and it's critical you do it. If you can afford to have somebody doing the manual techniques, or you have a spouse who can help you, or some other person in your life who can help you, all the better. So you're going to fall off the wagon. Things are going to progress, and then you're saying, I'm going to send you back, right? So most of my Hodgkin survivors are going in a couple times a year for therapy, and then not usually just PT. They're going in for PT, OT, SLP because they have some swelling issues or cog. So I'm a big relier on therapy services, and when I make that referral, the vast majority of my patients get those services covered. There are insurances that won't have OT services, for instance, or will have limited, but we always are doing it for a period of time, say 6 weeks, right? And you're going to have to get up to, and you're going to plateau, right? Then when we bring you back in, we're going to say, oh, she has worsening neck pain, and that's an automatic, nobody's going to deny that insurance again if it's 6 months later. I hope that's helpful. Not optimal for everybody who wants therapy all the time, but that's the way things actually work.
It is, and that's why the NHS doesn't fund it long term either. You might get a few sessions, but you're not, whatever your long term conditioner is, you're going to have to manage it with interim visits, really. Yeah.
But that's why, like, the Pilates for me is such a big thing, because that is something that's relatively inexpensive that will help keep you motivated and moving in the right direction.
Yeah, and I think a good yoga teacher will be very similar to a Pilates class as well. And again, if you can find a class where you've got an instructor who kind of gets that you're going to have some special need areas and there may be some things you can't do, at least initially, then attending that can be fun and motivating. Lungs. Is asthma more common in people who've had radiation? Or is it just that we can't breathe quite as well because of bits of fibrosis? Or what do you think's going on?
Yeah, so breathing problems in general is multifactorial. So the phrenic nerve becomes damaged, very commonly even paralyzed in some Hodgkin survivors, so it doesn't work as well. As I said, the bellow system, your chest wall becomes tight and won't expand well because it's fibrotic, right? So you can't take a deep breath even if everything else would let you, because you're in this tight cage. And then then the lungs themselves do become fibrotic. You get pulmonary fibrosis of those components of the lung that were not well shielded, which is most of it, and even through the shielding, they got some radiation. Then you may have cardiac issues. So having a heart problem and having the fluid, your blood back up into the lungs makes it stiff and makes it hard to breathe, right? Like somebody with heart failure. So there are a multitude of reasons why Hodgkin survivors can't breathe well. So, my job is not to give the exercises. My job is to figure that out. So that gets figured out so that we can optimize, right, what our approach to, to getting you to be better, right? Able to have more endurance, able to walk further, able to breathe better, to be more comfortable.
Okay, and so as a follow-up question for that about would you recommend inhalers, then I'm guessing your answer will be, well, that will depend on why I think you're breathless.
Exactly. So,
you know, if you're having a component of tightening or reversibility, which is an asthma type problem, yeah, inhalers might help, but otherwise they might not.
But yeah, I'm really enjoying working with you, Tess, because you are answering these for me, and I'm grateful for it. So she's exactly right. When you do those pulmonary function tests, one of the things that we're looking for is reversibility. They'll do a bronchodilator test as a component of it, and in that case, it may help. So all of this is very complicated, but knowable, right, with the proper testing.
Mm. And linked in without pulmonary effusions are occurring in our group because
we don't know. Yeah, I mean, it's a strange thing. I cannot explain why you get pulmonary effusions and pericardial effusions around the heart, both of which are not super common. It's seen, and it's just, you know, the bad answer is because it's part of the radiation fibrosis, but I can't explain exactly what it is about the radiation fibrosis that leads to those effusions, just the observation that they're seen, obviously.
Do you think it is linked in with the radiation?
Oh God, yeah, no, absolutely.
Yeah.
The radiation, I just can't tell you exactly which structure. When you come to me with a weak hand, I can tell you exactly what's been damaged. With the pulmonary effusions, I really can't, and I'm not sure if anybody else can.
Yeah. Okay. People are saying, so one person's saying, at least one person is saying, people are saying, can they consult with you from the UK? Will you do a remote consultation?
Yeah, I would love to, but I don't know. It might be possible as a self-paid virtually. Certainly I've had a number of patients come to me from the UK and I can see you in person. So that's not an issue. And I think we have a sort of a self-pay mechanism. I don't think I'm that expensive as far as doctors go. We're all about the same. But to do it virtually via Zoom, which I do, I honestly don't know. I can certainly find out and see if that's a possibility.
I think people might like to know if it was an option, and I guess a price guide would be helpful if people were going to be self-funding for something like that.
Yeah, I will. After I get off here, I'll email myself and try to find out both and maybe get that to you.
Yeah, if you get that back to me and Erin, then we can share it with the group. That would be helpful. And someone else has also said, whom should they see if there's no long-term specialists in their area? They've got a good GP, but they haven't got a good cardiologist or a pulmonologist, as you would call them, respiratory physician. What do we do? Other than we just keep trying to educate all those ignorant doctors out, don't we?
Well, so it depends on what you got. Right. So those survivorship guidelines that I had, and those are just out of a paper that I think get online. Those recommendations are pretty straightforward, right? So you should get an echocardiogram and an EKG annually. You should get carotid Dopplers if there's a bruit. Your GP can do that. And if the GP is not comfortable managing whatever degree of heart failure you have or a valvular issue that we find, then it's their job to share you with somebody who can, right? To find a cardiologist who can help you. So as you go down that list of common things, you just need to advocate for yourself. There's no rocket science here, right? There's a list of, 20 bad common things that need to have sort of a game plan for how to at least identify and then potentially treat them. So you can advocate for yourself by just kind of going through that with your GP. And if you kind of become too big a pain in the butt for them that they don't know how, then really just try to see if they'll refer you to somebody else. The harder thing is what I do, that sort of neuromuscular stuff. A neurologist is probably the closest. In the UK, I think they do have physiatrists, but they practice somewhat differently. For rehab docs, you do have physical therapists and occupational therapists, but it's, as you've learned, Tess, it's getting somebody who really understands you. So, there's not enough people who really know this, but this information is out there and not that hard to get anymore. It's not like when I started this where we knew nothing about the complications of survivors because we didn't have any until then. They're just starting to show up, right?
We have a Hodgkin's International survivorship care plan on our website, actually, which I've drawn up in conjunction with a local oncologist in Oxford, where I live. And it's not quite as specific as yours. We've tried to be as evidence-based and as internationally acceptable as we can be with it. But we have covered all of those issues. And the idea is it's something people can print out or download, fill in, take it to their physician, take it to their specialist, and just go, look, there's this organization, Hodgkin's International, they say there could be a problem here. So we're trying to advocate for people, help people advocate for themselves, really, by giving them that information to take out there. What else? People have asked about social security disability process and so on. Are there any recommendations for improving the chances of getting approved for that? Again, we're in the state here.
Yeah, I'm not really an expert there. I've certainly, do very strongly worded letters for disability. But, it really, that usually starts, because disability comes from all different places. And I usually have the patient start that. In terms of advice, it's like whichever doctor is advocating for you kind of helps if they understand what's wrong with you. So if you're finding somebody who's basically saying you have fibromyalgia and you're malingering and there's nothing wrong with you, you probably need to find somebody who is going to write a more strongly worded letter.
Thank you. So someone said, what about old age? How should we be thinking about our chances for achieving old age? What are the statistics, or are there statistics, or how can we understand how we age compared with the general population?
Yeah, well, I liken Hodgkin's to an accelerated aging process, certainly, but with obviously a lot of caveats. There's a lot of people here who are on their 50s, 60s, and I dare say 70s that, as I kind of look through. So you're already starting to become a not young group, shall I say. So you're living the dream. And what does that mean? It means that the two things that are going to kill you are secondary cancers, and there's screening guidelines for those that I kind of posted, and cardiac disease, which is something that you can easily sort of follow. So those are the two things. All the stuff that I treat, right, is the stuff that I kind of joke is going to make you wish you were dead: the neck pain, the fat cactus, you can't hit your head up, your arms get too weak, you can't play with your grandchildren, that sort of thing. While we can't cure that, we can certainly optimize you as much as possible. Those things are going to get worse over time, right? The longer you live, just like old age, you're going to have more neck atrophy, more trouble lifting your head, potentially weaker arms, and other things are going to go. But that doesn't mean that you can't enjoy function and quality of life. It just means this is part of the whole process. And everybody goes through it at a different rate. Some people do shockingly well, and others get issues early and in a really bad way. And there's no real rhyme or reason, at least that I understand, why that is. So my advice to all of you is you're clearly interested in, in how you're going to do, because you're watching this talk. So you're already in this great position to advocate for yourself. And all I can say is keep doing that and keep doing the things that you enjoy, and keep doing activities with the time and energy you have, like you have, Tess, right, to make you be able to live the life as well as you possibly want, right? This is no different from if you had a stroke later, or you got into an accident or whatever. Doesn't mean you give up on life. It means that you have to work to live the life as well as you possibly can, given the hand you were dealt.
And that I would urge people to consider the psychological aspects to that as well. It's about learning to cut your coat according to your cloth, I think, in a way, and so that you have realistic goals for what you hope to achieve, and what we might call a cross-eyed approach as well, where you're hoping for the best but also preparing for the fact that you may not be able to do as well as you want to. So I think those things are important, and get psychological support, because actually that will have a big impact on your quality of life, won't it?
Yeah, absolutely. Well said.
I just want to jump in. Excuse me. I just want to jump in here because we are at the end of our time, and that seems like a good place to end on the positive note of living, one day at a time and doing what you love. I think that's a great place to end. But I want to truly thank Dr. Stubblefield for being here and for taking on all these questions without missing a beat or taking a breath. It was an amazing thing to watch. the great news is that we are recording this and we'll make it available to anyone who wants it. And thank you to Tess, who handled the hosting job beautifully, both from a physician perspective and from a beautiful voice and caring heart perspective. That was absolutely fantastic. So we'll let you all go and get back to your day or evening, whatever's left of it. And again, thanks everyone for coming, and thanks so much for Dr. S and Tess for leading the way here. Much appreciated.
All right. Well, thank you, everybody, and I wish all of you well.
Thank you.
Thank you so much.
Take care, folks.
Take care and thank you.
Goodbye.